Hi, we're just going to record this tutorial for your information. Just review the learning objectives for this tutorial, and now we'll start with the information that we discussed during the tutorial. So in Module 2, what we looked at is pre- and postnatal care. So we discussed the ideas around preparing the woman for pregnancy, her diet, her health, her risk factors, aspects like her previous medical and surgical history, and then was there any risk factors in relation to drugs and alcohol. There's also those conversations about contraception. What had they been using, what types would suit them, and you as the nurse needing to know of the efficiency of different types of contraception. We also explored the idea of mental health, looking at evaluation and care for the woman during and after pregnancy. The last aspect we looked at in Module 2 was intimate partner violence, and we discussed the policy and what the nurse's role is. And one of the important things to think of is the nurse's role in just making sure the woman is safe. So in relation to pregnancy, we also discussed breastfeeding throughout the pregnancy and her ideas of how she was going to feed the baby. We looked at the nurse's role in discussing and supporting the woman during this time, which included nutrition and also the aspects of partner support and support that she received. We talked about the lactation consultant and also Nursing Mothers as a support association. And we also discussed the policies in relation to postnatal period and breastfeeding. We looked at the length of pregnancy and the different aspects within each trimester. So the first one often being that risk factors of miscarriage, nausea and vomiting, and also early pregnancy concerns in relation to intimate partner violence and why they might come into hospital with urinary tract infections and other infections. We talked about trimester 2 being the time where it is the most time of the baby growing, assessments, risk factors such as gestational diabetes and pregnancy-induced hypertension, and what your role as a nurse is if these people come into your clinical area. Then in the last trimester, it was more about preparing the woman for delivery and feeding the baby in the postnatal period and the risk factors in relation to premature birth and mental health.
And I think the important thing to remember is that we're not preparing you to be midwives, but rather those key aspects and elements and principles of care during the pre and postnatal period for women who you may care for in your general surgical wards, if you're working in community health, or in fact any area that you might be in where you might be required to care for somebody during pregnancy or during that postnatal period.
And so this was just a little snapshot of some of the assessments. So we talked about the assessments for pregnancy, which are really sort of the basic ones. If you have this woman come in, it's about sort of your vital signs, your baseline assessments, looking at height and weight to get a BMI to see whether the baby's growing well, and also sort of fetal movements and general discussions of how well she's doing. We also then looked at the reflexes and the Apgar score in relation to the newborn.
So when you're looking at these and reviewing this in your modules, think about these reflexes as part of that neonatal newborn assessment. And these are classed as primitive reflexes, which should disappear in the weeks or months following birth. And then when you're looking at the Apgar score, so we're looking at a newborn baby already being assessed within 60 seconds of having been born. And 60 seconds can be quite a long period of time. So make sure that you're familiar with what each of these elements are, because they're quite different to our normal ABCD type acute assessment. And they're quite different what we're looking for in a newborn as they start to make those physiological changes and respond to not being in utero anymore. So you need to understand what each one of those of the acronym stand for.
And then we went on to Module 3.
Okay, so what we wanted to look at today, not a review and a summary of Module 3, but rather looking at some of those aspects of child safety, which include injury prevention and mandatory reporting that we only just went over very briefly in the tutorials. So if you remember back to the tutorial from this module, we covered all of these except child safety in any detail, because we did say we would come back to that during this tutorial. So we're going to focus a little bit more on that. So this is some data that came from Australian Institute of Health and Welfare in 2016. I haven't been able to find more recent data on this, but basically what it's saying to us is that boys are more at risk of childhood injuries than girls. And that falls, unlike in the elderly population, falls are all those childhood accidents where they might fall off a swing, fall off the slide, fall out of a tree, fall when they're playing on a trampoline, fall off a push bike, whatever it might be. And often it's related to their level of development where they're actually trying to push those fine and gross motor skills beyond the stage of development that they're at. So if you go back and refer to the module, there's actually a number of social policies and safety policies that have been put in place to try and correct this imbalance. So things like pool fencing, car safety seats, childhood, different types of childhood safety restraints. So those types of things are now law and legally required. So there's been a lot of work done in that space to try and reduce childhood injuries. The other thing that we might have spoken about in some of the tutorials, but which is a very specific ruling only in Queensland, although I believe it is used in some of the other states. So a young boy presented to a regional hospital with an undiagnosed strep infection, and that led to toxic shock, and he ultimately passed away. His parents were really worried and voiced their concerns quite regularly to a number of staff, but they didn't feel that their concerns were acted on. So it went to court, there was a huge review, and the Department of Health introduced this escalation process. So it allows the family or the carers to escalate their concerns to try and prevent this type of thing happening again. So if your child is admitted to a hospital anywhere in Queensland, they will be provided with information about Ryan's rules. So it is an escalation process. It's not something that a nursing staff member would do. This is something that family members or the child's designated carer, grandparent, can work through. So there's a number of steps where they might identify to another nurse or another doctor that they're concerned about the care that's being provided. If the patient isn't improving or they think that their condition is getting worse, they can then ask to speak to the head of the department, whether that's a nursing manager or a medical officer, and then they will be stepped through what that process is and need to provide a range of details and information. This is separate to general complaints about the food or the waiting time or any of that sort of stuff, and all of that can still be done on the health website, but this is a very specific rule around deterioration of patients. The other thing that we did talk a little bit about, and again we talked about child abuse or suspected child abuse or neglect. So last century, at the end of the 20th century, so 1999, a Child Protection Act was put in place, which required a range of professionals, not just health professionals, to have to mandatorily report to whoever the Child Safety Commission is, and they have different names in each state. Mandatory reporting applies to a lot of different elements. So at the moment, in the middle of a pandemic, mandatory reporting of a positive COVID case is a public health requirement. Professional mandatory reporting. If you see something that's unprofessional, again, as an AHPRA registered health professional, you're required to report. This mandatory reporting is only in relation to a reasonable suspicion that a mandatory reporter might have, that where you think a child might have suffered, is suffering, or is at a very high and unacceptable risk of suffering harm from physical, sexual, mental, coercion, whatever it might be, that they're at risk of abuse or neglect, and there doesn't appear to be a parent or an adult or a carer who is capable or willing to protect them. So you can see the list here of professionals who are required to report, and that includes registered nurses, but not student nurses. So your role as a student nurse is to talk to your registered nurse that you're buddied with. If they still aren't wanting to report or they don't have any concerns, you could talk to another health professional. It might be the charge nurse, it might be a medical officer, it might be a social worker. So your role is to voice your concerns. Your role isn't to report.
And I think one of the things is to be aware of this when you're in those paediatric or emergency areas, and maybe sort of if there was a situation, just to understand. So when you become the registered nurse, you've got that baseline understanding of what this reporting looks like, and to actually read over that policy yourself so you're understanding.
So there's a couple of, there's actually 3 videos. There's 2 videos that relate specifically to mandatory reporting and the Child Protection Act. They're very short, they only go for 3 or 4 minutes. Then there's another video that's been put together by one of our clinical partners, where we often place students, and she talks quite specifically about what the role of the student nurse is in regards to mandatory reporting, and also identifies that really important step in this process of ensuring that you discuss and debrief if you've been witness or have any sort of suspicion, because it can often trigger memories for yourself, or it can be quite confronting and quite challenging. So while you're working through this module, I want you to have a think about what your response might be if you observed suspected child abuse or neglect. Think about some of those feelings that you might have, and these might be shock, it might be anger, you might feel very confronted, you might feel very concerned, you might cry. And all of these are really normal and typical responses to seeing something that most of us won't see. So make sure that you not only identify that these feelings are there, but that you talk to somebody about them, and just really identifying and acknowledge that importance of self-care when you're part of that assessment process or caring for a child who has been suspected to be abused or neglected. Okay,
so then we went into Module 4, which is looking at the developmental changes of adolescents. And so we went over sort of what we'd passed in the actual module: physical, psychosocial, social, cognitive, behavioural, and also sort of explored that sense of identity as they become sort of moving from child, adolescence to our emerging adult. And we discussed sort of the protective factors and risk factors involved with this. And one of the things that we looked at was the assessment scale of HEADS. And so just refresh your memory as you're going through this module of what that stands for and what that means, and how those questions could be used in your clinical practice to sort of ask how this adolescent is going. If we change slides.
Yep. Oh, I was just going to add in that we talked a lot about age range and what we identify as that age range for adolescents, and you'll see anything from 11 to 20 or 13 to 25. And just remembering that unlike the age group before that, where we can fairly clearly say at this age range this is what they'll be doing, with adolescents those physical, psychosocial, behavioural changes can happen at any age throughout that 11 to 20 age bracket, if you like. And that sense of an identity and that clearly emerging adult can happen quite late for some and very early for others. And think about what that might mean in connection with those protective factors and risk factors. There's actually a really great section in the module relating to protective factors and risk factors. There's a really good diagram there that spells out the key protective factors that have been identified as being protective of those risk factors. So when we talk about risk factors, we always like to look at, well, what might protect or remediate or assist or reduce risk factors. So that's what the protective factors do.
And then we looked at sort of the health issues for adolescents, and I think particularly the ones that you'll often see if you're working in that paediatric area or an emergency, are the ones that often relate to a physical concern but with an underlying mental health issue as well. And so, as Hazel was saying, it really does depend on the sort of the developmental age as opposed to the actual age of the adolescents that you're working with. and really being aware of the sort of common causes of hospitalisation, which clearly relate to risk factors, because they can be, again, that sort of falls and transport accidents, which are sort of the highest cause in relation to hospitalisation for adolescents.
So there's a similar table for adolescents to the one that I just showed you for childhood hospitalisation. So that one that we looked at before related to actual hospitalisations related to those injuries. So there's another chart in there which we probably should have had it in here, but that's okay. And it's quite different to the younger age group. And again, males have more admissions related to injuries and accidents and illness than females, except in one area, and that relates to the area of self-harm.
Yep.
And mental health or attempted suicide issues, but generally self-harm, where female admissions are significantly higher than males.
Yep. And so the other aspect that we looked at was just that sort of health assessment for adolescents. And this was sort of really covered quite well in the tutorial on adolescents as well, where we sort of talked about that key principles of developing that therapeutic relationship, which was really about that sort of building trust. And one of the things that we talked about is the age of consent. And so sometimes, again, with that sense of maturity is not related to the age, but maturity of the adolescents. And so deciding whether they are sort of at the age of consent, and that is the Gillett assessment. I don't think I've pronounced that correctly. But yeah, so just sort of that there'll be times where it'll be important to actually have the one-on-one conversations with the adolescents, and some other times with the parents or caregivers in that same area. And that really is that conversations you as the nurse has with both the adolescents and the family.
And as Elizabeth mentioned before, one of the most common tools that's used for assessment for adolescents is the HEADS tool, so making sure that you understand what this acronym is for, what each of them stands for, and if you have a look at the sample that we've given you on the course site, it gives you example questions for each of those. So, you know, things like the first one, which relates to home and housing, you know, who do you live with, where do you live, are there any concerns at home, do you feel safe at home? So, you know, each of those has a series of questions that nurses can ask. And for those of you who complete a mental health placement where there's younger people there, they'll often use this in the mental health space as well to get a really good understanding of where that adolescence is, and they'll also use it in emergency department when young people are being admitted. So it's a tool that's used internationally. It's not just an Australian or Queensland specific tool. Has slightly different variations depending on the setting, but we're just looking at a fairly generic one in this instance.
And again, as always, in every area in relation to sort of child and family, there's policies. So make sure you sort of had a look at the policies, and Eileen presented this one as a very new one with an interesting acknowledgement to the impact of COVID on young Australians.
Okay, so again, when you're doing your revision, make sure that you're thinking about, okay, so what you really want to know is what questions are we going to be asked, whereas what we're wanting you to know is how does it all fit together? So what? How do all the dots join together? So thinking about, like you did in your assessment task, what's a strategy that you might use to support an adolescent and their family when they come in? What sort of resources can you refer them onto or show them or demonstrate to them? Because we know that this particular age group continually say that they're experiencing stress and anxiety, and for some they may be diagnosed with depression as well. So think about, you know, the content that you've got, what we've gone through in the tutorials, some of the case studies that we've looked at, and come up with some of those strategies that you as a nurse could suggest and implement for the families that you're caring for, and then think about the resources that might be appropriate for that particular age group, depending on what their concerns are.
And that brings us to the end of the sort of tutorial information that we went through in this week. Thank you.